Hi, everybody. Thank you so much to the organizers for including me yet again. This is really the highlight of so many different meetings, and I just marvel at how much you've put together. So I'm going to try to cover the current treatment of aggressive B-cell lymphomas and then T-cell lymphomas and set the stage for the next two talks that are coming that'll build out on bispecific agents and CAR T-cell therapy. Here are my disclosures. The last few. Okay, so I'm going to start with diffuse large B-cell lymphoma. And I think, a couple years ago I was honored to be the Howard Ricketts lecturer here, and I gave a bit of a history about diffuse large B-cell lymphoma. For the purposes of today, I think there's really, a pre-2017 approach and a post-2017 approach in my mind. Prior to this time, we had, R-CHOP, and if R-CHOP didn't work, second line was transplant, and if transplant didn't work, there was really nothing there. Of course, this all changed with the advent of CAR T-cells in November of 2017, and since that time, we've been in this era of just sequential FDA approvals that have improved outcomes for our patients and given us this entire arsenal of options to choose from. Just in the last year or two, we've had another several new regimens approved or new approaches approved, including one just in February of 2025 with BV plus lenalidomide and rituximab, and I'll go through that in just a moment. So I'm going to cover a number of trials that were updated in 2024 or 2025, as well as some abstracts from ASH, and focus on both items that are FDA approved, as well as those concepts that are emerging. There are a couple things here that I'm going to kind of go over very quickly because they are covered in the subsequent two talks, but really just to give you a flavor that this field has gotten so exciting and very, very complicated when it comes to picking treatment. So to start with the first-line therapy, we've talked about the POLARIX trial several times, and as people may remember, this is the comparison, a prospective, randomized, double-blind, placebo-controlled trial. So really, the epitome of how trials are supposed to be designed, comparing R-CHOP, standard R-CHOP, or with the replacement of the vincristine with polatuzumab vedotin, which binds to CD79 and delivers MMAE as a payload. It's important to remember that this trial was for high-risk patients, so this is for people who have an IPI of 2 or greater, and that the primary endpoint was progression-free survival. What we saw at the initial publication in the New England Journal of Medicine is that for the first time after sequential R-CHOP plus X approaches, we had an improvement in progression-free survival of about 6.5%. Well, what was new in the last year was the 5-year update, actually the 6-year update, sorry, I'll get to that in just a second. One of the pieces that happened with POLARIX that we talked about before as well is that people have tried to parse out, does everybody need Pola-R-CHP, or are there subpopulations that may benefit more, and contrary, others who may benefit less? So in the initial forest plot, it looks as if Pola-R-CHP is better for those patients who have some favorable and some less favorable features. So those patients who have a good performance status and non-bulky disease and don't have double-hit lymphoma or triple-hit lymphoma tend to do better. On the other hand, some previously high-risk features such as older age or ABC subtype also did better. So we start to see the population where it might be enriched for response. However, I'll just caution that the trial was not designed to directly look at these subsets, and right now the indication is for anybody with an IPI of 2 or greater. So with the prolonged follow-up, the progression-free survival benefit has been maintained. The hazard ratio for overall survival has not reached significance, but you can see that it is 0.85, and I think this is very, very encouraging. It may be more and more difficult to show improvements in overall survival as our second and third line treatments are improving. And sort of on that note, when they did a subset analysis at ASH this year and in their subsequent publication, it turns out that when you look at how many of the patients who were enrolled onto Pola-R-CHP or on the POLARIX trial in general became candidates for second-line therapy and actually received second-line therapy, the numbers, if you look at the box on the right, they're actually quite low. So, this is both a good news and a challenging situation in the sense that if patients are doing better and better, it may be that our second and third line therapies are going to have a smaller population with which to focus on. Despite trying to replace R-CHOP, I think it remains the backbone, and I'm just going to share some unapproved trials that are looking at building on R-CHOP. The first is with a cell mod called golcadomide. This is different than an immunomodulatory agent such as lenalidomide. It does share the fact that it binds to cereblon, but it has an enhanced ability to increase degradation of transcription factors such as Ikaros and Aiolos that leads to a more favorable phenotype within the cancer cell and might sensitize that malignancy to the chemotherapy. And then, of course, bispecific antibodies such as epcoritamab and glofitamab have both been tested with R-CHOP, and I'll share some of the more recent data. Okay. So the first study is golcadomide plus R-CHOP in treatment-naive diffuse large B-cell lymphoma, and this was randomized really just to look at two different dose levels. It's not a true randomized study, but it was looking at safety and tolerability, and then also trying to determine some preliminary efficacy. They also collected ctDNA, so I think at some point we will get some information about this type of correlative. And just in terms of patient characteristics, the median age of this patients enrolled was 62, and 80% were high risk, defined by either a higher risk IPI or to have adverse biologic features such as double hit or triple hit lymphoma. Their preliminary data, as presented just a few months ago, looks very encouraging in that they had a very high complete metabolic rate without an increase in toxicity. And they found that with a 1-year PFS, this was very encouraging at 85%, particularly for the higher dose. We also found information about epcoritamab plus R-CHOP in a single-arm phase 2 trial, and again, this looked at high-risk patients. I think this trial actually had higher risk patients than even the golcadomide trial in the sense that the IPI was at least 3, and they included patients with an adverse performance status. So the key patient characteristics here that I want to highlight is that half the patients had an IPI of 3 and half the patients had an IPI of 4 to 5. So in this, and a third of patients had bulky disease. So in this setting, I think it's very intriguing and that there's a high CR rate across all of these risk groups, even though the numbers start to get small. And I hope that this phase 2 study, continues to give us information and we can learn from it going forward. As expected, the highest risk of CRS, which is shown in the bar plot to the right, is with the escalation of the epcoritamab, which is on cycle 1, day 15. But this is something that was manageable, and the vast majority of CRS events were very low grade, and there were no new safety signals. So small study, single arm, high rates of MRD negativity, encouraging PFS and OS, and I think we'll see what happens. The next study that, again, is not approved, but I think is somewhat provocative, is to say, do we need the chemotherapy at all? What if we just use the bispecific? And this was a study, a randomized phase 2, looking at epcoritamab versus epcoritamab plus lenalidomide, and looking at patients who are considered ineligible for anthracyclines or have, noting that they often have a worse outcome if they can't get anthracyclines. And the primary endpoint here was complete response rate. In general, this was for older patients, and they had 120 screened patients. Only 88 were randomized, and only 45 to the EPCO monotherapy arm, which is what they presented. Within this, I just want to say that the reasons for not using an anthracycline, I think, are maybe a point of discussion. In 78% of the patients, hypertension was one of the contraindications, or they had increased cardiac enzymes, minority had AFib, and I think this really begs the question of how do we assess frailty, how do we assess ineligibility for anthracyclines when we are in clinic? Nevertheless, looking at EPCO monotherapy, and 40% of the patients were between the ages of 80 to 85, and 38% were over the age of 85, so really a much older and frail population. And what they found with a very short follow-up is that they were able to achieve some disease control with a 6-month PFS and OS, as you can see there. I am I would like to see the whole publication here because there were some deaths, including deaths from progressive disease, high CRS rates, although they were low grade, and maybe a little bit more ICANS that you might expect in some other settings. But, you know, these are, again, are patients between the ages of 80 and up to 92 who really cannot get other types of therapy, and perhaps there's something here to build upon. So what's next for treatment-naive diffuse large B-cell lymphoma? You know, I still think that anthracycline-based chemotherapy is the standard of care, but, you know, it's hard to break out of the R-CHOP plus X mode, and I know at MD Anderson and other places there are some non-chemo approaches, and perhaps that's something we can see as things go forward. And then I do wonder if the cure rates are improving, what is the demand for second-line therapies going to be? And, you know, if we're successful, there won't be any, although we're not quite there yet. And the final question, of course, is that we continue to lack precision approaches in this disease. There are a number of attempts being made around the country to try to develop a precision approach, and this is just one example. This is using the LymphGen classification that was from the National Cancer Institute that divides diffuse large B-cell lymphoma into one of several subgroups based on gene expression and genetic profiles, and also combining in some copy number variations. This is not the only infrastructure or framework that's being developed. There was a publication from Margaret Shipp just a few months ago showing a slightly different way of categorizing patients with DLBCL that may be a little bit more inclusive, but there's trade-offs between all the different systems, and this is also being refined at different institutions such as British Columbia, through the Mayo Clinic, and also through MD Anderson. So we'll see, but through the intergroup, the hope is to design a precision approach, and Brad Call and Brian Hill are leading that effort. So switching to relapsed and refractory diffuse large B-cell lymphoma, we actually have a new FDA-approved indication or regimen today, and that is based on the Echelon 3 study, which was a randomized prospective phase 3 trial of BV, brentuximab vedotin, plus lenalidomide rituximab against placebo R-squared. The interesting thing for this study, this was meant for older adults, and so even though it's age over 18, as you'll see in the patient characteristics, most patients were actually older. They did not necessarily have to have CD30 positivity. I thought that was quite interesting, and it was either less than 1% or 1%, and the primary endpoint was overall survival. So if we dig into who was actually enrolled, you can see that there's 155 patients who were over the age of 65 and 86 who are over the age of 75. So really, this is a much older population, and you know, this included patients with transformed disease. About a third of patients on both arms had transformed disease, and the CD30 status was actually negative. It was less than 1% in about 2/3 of patients, 60 to 70%. I think we were all really surprised to see that there was an actual overall survival improvement when BV was added to R-squared, and this was true in both the quote-unquote younger as well as older groups, 65 or 75, and you can see the overall survival differences here, which were statistically significant. This was also true for progression-free survival, and I'll just say that the PFS was doubled, although it is going from 2.8 months to 5.7 months. So, you know, we can say, like in the relapse and refractory setting where we have a number of different things being developed, you know, this is something we want to think about, but it may or may not be appropriate for everybody. Over the next few slides, I'm just going to go over just what's going on that's not yet FDA approved, but this particular one is listed in some of the NCCN guidelines. So STARGLOW is a trial that was looking at chemotherapy in the second line or beyond setting versus chemotherapy plus the bispecific agent glofitamab. And you know, this is really meant for people who are not transplant eligible, and it's GEMOX for 8 cycles. And what they found with a median follow-up of 20 months is that there is an improvement in overall survival, to, almost a doubling, 12.9 months to 25.5 months with a hazard ratio of 0.62. And there also appears to be perhaps a plateau on the curve. And I thought this was very exciting to consider that maybe there are some patients who are still eligible for intensive therapy, but perhaps not for an auto transplant. The next two slides, I'm going to just talk about regimens that are approved for relapse refractory large B-cell lymphoma where we had an update. The first is Tafa-Len, now with a median follow-up of 44 months. The depth of response seems to predict the outcome, and you can see again that there is a plateau on the curve, and there are some very durable responses. The other is with loncastuximab tesirine, so this is an enhanced CD19 antibody drug conjugate. And this also shows that those patients who have a CR, perhaps there is a bit of a plateau on the curve. So I think when it comes to relapse refractory large B-cell lymphoma, we're trying to pick between a number of very active agents. The last two studies I'm going to show in this setting are looking at building on polatuzumab vedotin. So the first is to look at glofitamab plus pola. This, as you've heard about earlier from other speakers, obinutuzumab pretreatment is required as part of this regimen, and there is an admission that is required for cycle 1, day 8, which is when you have most of the escalation. In this pilot study, there were some very nice response rates. Again, this is relapse refractory large B-cell lymphoma, and there was a 66% CR rate amongst the high-grade B-cell lymphoma. So amongst patients who have a very tough situation in the relapsed and refractory setting. These are the Kaplan-Meier curves, basically showing that after fixed duration treatment with this polatuzumab-based regimen that includes the bispecific agent, there are encouraging outcomes. This actually is up to 2-year data. So again, we used to think about large B-cell lymphoma as having a very 6-month dismal outcome after if transplant was not an option, and here we have some encouraging combination data. The other bispecific POLA study that was presented by Elizabeth Buddy is a randomized phase 2 study of mosunetuzumab subcutaneously with polatuzumab, again in a very high-risk population. This one has the advantage that there is no admission required, and the mosunetuzumab is also given as a subcutaneous administration. So the follow-up here is a little bit shorter. It's only 18 months, but again, the takeaway point is that CR matters, and that if patients do have a CR and it's sustained at 3 months, those patients actually have a really impressive outcome. So I'm going to move on and just say that there are some studies that are going on within the NCTN, and these are available to you through either the cooperative groups or NCORP. And one is S2207, which is a randomized phase 2 building on Tafa-Len in the relapsed refractory large B-cell lymphoma setting. And the other one is a post-CAR T-cell optimization looking at those patients who have an incomplete response. And maybe we'll hear more about it from Matt Lunning. In the last few minutes, I'm going to talk a little bit about T-cell lymphomas. And this is, of course, a very, very different mindset when we're approaching this group of patients. There were 3 abstracts at ASH that I thought I could talk about that one sort of confirms the current approach. The other 2, I think, are promising new directions that are upcoming. So just by way of background, we know that T-cell lymphomas are a very different beast than diffuse large B-cell lymphoma. They are rare, they are heterogeneous, and they generally have chemoresistance as the foundation of how they behave. There's only about 7% of all lymphomas, and today we approach it by dividing this bucket into 3 different groups. The first is ALCL, or anaplastic large cell lymphoma, which is universally and strongly CD30 positive and can come in either ALK positive or ALK negative flavors, and is characterized by sheets of large cells. The middle group is sort of a newer group that has been described over the last decade, and that is angioimmunoblastic T-cell lymphoma, where we now know that the cell gone bad is a T follicular helper cell. And in fact, there's a number of previously considered PTCL not otherwise specified that have the T follicular helper cell phenotype and have now been lumped together into this category. The diagnostic criteria require either BCL6, CD10, PD1, CXCL13, or ICOS expression, and those groups have now been combined. And then anything that's left is PTCL, not otherwise specified. A lot of how we approach PTCL comes from observational studies, and this is just one of those from about a decade ago. And a couple of things to point out on this. The first is that ALK-positive anaplastic large cell lymphoma is clearly an outlier and does better. Although, I will say, especially from a recent experience, there's still a 30 to 40% mortality rate over the first decade, and the progression-free survival is really hovering around 50%. So although we call it the good of the T-cell lymphomas, it's really not all that good. The other piece that we can take away from this figure is that almost all of the recurrences occur early, and that with CHOP-based treatments, the vast majority of patients will have progressed by the time 1 or 2 years goes by. So, really about 30 to 40% of patients will remain progression-free with our current approaches. This has led to a paradigm where we use the anthracycline-based induction regimens, but we always follow it with a beam autotransplant or some other conditioning regimen, an autotransplant with high-dose chemotherapy. And the question is that really still what we want to do? So just before I get to what was presented at ASH, just to remind everybody, one of the two sort of data sets that really ushered in transplant consolidation for T-cell lymphoma. One is the Nordic data set, which looked at auto-transplant consolidation in peripheral T-cell lymphoma in a variety of settings. And what they found is that there is a plateau on the curve, so perhaps we are curing some patients, and that again, it seemed best for ALCL and worst for some of the primary extranodal lymphomas like EATL. This is important to know that this includes an ITT population. So in other words, when we look at registry data, it's only the patients who actually got transplanted that you're looking at, whereas this was a little bit more of a population-based evaluation. The other prior data or background is that a Dutch registry showed that patients who had transplant, which is the red arm, versus no transplant, if they achieved a CR, do much better. And so again, this sort of sets the stage. Well, is this still what we should or could be doing? And EBMT at ASH this year did an analysis of 10,000 patients with PTCL and looked back to say, what was the outcome with first auto or first allo? And for the purpose of this discussion, I did not include the allo data. I'm just focusing on the auto. And for that group, it's a relatively young population. The median age is 56. This was a mixture of first-line and second-line patients, which makes it a little bit harder to interpret, but more than half the patients were in their first line of treatment, and 72% had a CR1 or a PR1. And what you can see over on the right side is that this is what we can tell our patients. What do you expect if you get to transplant in a CR or in a PR, especially in the frontline setting, is that about half the patients will be progression-free at 2 years, and about 70% of patients will be alive at 2 years. So it gives us a little bit of a bar, to work with. Digging into it a little bit more, obviously the histology matters, and so those patients who have ALCL did much better than other patients. And I think this is a nice sort of modern bar, if you will, for us to look at. So there's 2 studies that are going on right now that I wanted to point out. The first is questioning whether or not we can build on CHOP or CHOEP. And this is, again, an intergroup study that looks at patients with untreated PTCL and adds in either the PI3 kinase inhibitor duvelisib or the hypomethylating agent azacitidine to the CHOP or CHOEP backbone. And this trial is ongoing, and I think will be very helpful for us to know whether or not, looking at biologic agents will make a difference. The other question is whether or not we still need transplant, right? We know that these patients don't do very well. Is there an added value to that toxicity? And so EA4232 is also enrolling now, and it is a 1-to-1 randomization between observation or transplant. And I think this is a very important study for us to try to enroll to. Unfortunately, in the relapsed and refractory setting, there is only a laundry list of options today. There is nothing that is even close to sequencing. But at ASH this year, there were 2 studies that I thought I would point out. The first is about duvelisib. And now we've already had some preliminary data from Steve Horwitz and others that this PI3 kinase gamma delta inhibitor, which is an oral agent, has some encouraging activity in PTCL based on some phase 1 data. What we saw this year was an expanded population, Now, over 100 patients, so 123 patients with PTCL, looking at duvelisib monotherapy, showing that the overall response rate is 48% with a CR rate of 33%, and this is in the relapsed and the refractory setting. There may be some differences where it seems as if those patients who have AITL have a slightly better response rate, but again, this is a very small study, but at least encouraging to see that there is some activity. One of the pieces they went back to look at was to say who did not respond, and it turns out that having a JAK-STAT mutation predicts for non-response to PI3 kinase inhibition. And so they looked at this and looked at the number of patients who had the mutations that were enriched among non-responders to duvelisib-based therapy. So based on that rationale, there was a dual-targeted study looking at both duvelisib as well as ruxolitinib, which is an inhibitor of JAK that we are familiar with from our myeloid experience. And what they found is that there is some toxicity, thrombocytopenia and neutropenia, but when it was overall well tolerated, and compared to the duvelisib monotherapy, slightly more LFT abnormalities, but much less diarrhea and no rash and no pneumonitis. So now there's the thought that perhaps if we combine ruxolitinib with duvelisib, maybe we are mitigating some of the toxicity that we think about with the PI3 kinase inhibitor duvelisib. So they did look at efficacy by histology, and again, the AITL has, I think, the highest response rate, which is 79%, compared to some of the other histologies. The other group that they saw very high response rate, although it's only 5 patients, was PLL, and I just have the swimmer's plots here showing the number of months that these patients in the relapsed and refractory setting have been able to stay on this regimen. And again, something that is food for thought. And then just the very last slide here of data is the RADAR study, and this was for relapsed refractory CTCL or PTCL that looked at dose. It was a phase 1 dose escalation trial of a lenalidomide backbone with the HDAC inhibitor romidepsin, azacitidine, and dexamethasone. Again, a small study, only 26 patients with a diffuse distribution of histologies, but the overall response rate is 63%, and there were even some CRs, and perhaps very intriguing is that there were at least 2 patients who stayed in remission for over 36 months for a fixed duration type of approach, and I think that is something that is particularly exciting. So for peripheral T-cell lymphoma and CTCL, I think anthracycline-based chemotherapy plus an auto transplant remains the standard of care. I think we are all questioning whether or not the added value of transplant is true or if it's only selection bias, because most of the reports only tell us about those patients who actually had the transplant. And then there's a number of targeted approaches that are in development. I really hope, similar to diffuse large B-cell lymphoma, we are right around the corner of a huge breakthrough for this group of patients. So with that, I'll just say thank you again to Dr. Birahay and the organizers for inviting me to be here. We are opening our new freestanding cancer pavilion in 2027, and I welcome you to Chicago. Thank you.